Hello students, in this session we will try to learn something about the baby shock absorber. Let me call it so, that is the amniotic fluid. So the basic fluid mechanics, how is it formed, what is its function, and with the abnormalities in the quantity of this amniotic fluid, what are the situations that we can encounter, how they are caused, and what should we do if we make a diagnosis that either the amniotic fluid is decreased or that the amniotic fluid volume is very high. So these things we shall just study during this current session. You know, in the first 10 weeks of gestation, the amniotic membrane alone is responsible for the secretion of amniotic fluid. Between 10 to 16 weeks of gestation, the fluid is a transudate of the fetal serum via the skin of the baby itself. You know, the skin of the baby can allow the fluid to pass through it into the amniotic sac, right? So this fluid is mainly a transudate and it contains mainly the fetal component, fetal serum component, and it comes via the skin and also the umbilical cord. After 16 weeks of gestation, it is mainly produced by the urinary secretion. The amount of urine secreted by the baby determines the fluid mechanics, the amount of fluid and maintenance of this fluid, and also partly by exudation from the fetal lungs, right? So if you just try to study the mechanics, you know, the fetal swallowing and reabsorption by the intestine. Okay, fluid that is accumulated in this amniotic sac, the baby will be swallowing and it gets into the system, GI system, which is absorbed into the circulation of the baby through the intestine. This is one way in which amniotic fluid goes into the system. Exchange with respiratory tract and reabsorption via lungs. Okay, the aspirate also goes to the lung, and in the lungs the fluid reabsorption occurs, right? And exchange across the fetal skin is possible only for small lipid soluble gases. Across the skin, it is possible only for the gases and not the liquid. Fetal urine is the major determinant which increases the amount of fluid, right? And you have secretion from the amnion, and there is an interchange from the amnion and the chorion across the chorionic plate. So this will be there, mainly the water exchange between the mother and the fetus. So there is some placental exchange, there is a very small skin exchange of gases, and the lungs play an important role in, one is exudation, other is absorption, and gastrointestinal system plays a very important role by the fetal swallowing mechanism and reabsorption of the fluid. And major composition is because of the fetal urine. Why I want the students to understand it better? Because in case of problems in the baby, anything that comes with swallowing mechanism can increase the fluid. Anything that decreases the mechanism of urination, for example, renal agenesis, or sometimes there is a posterior urethral valve. In such cases, baby will have severely decreased, very greatly decreased amount of amniotic fluid, right? So for this, you people should understand how the amniotic fluid moves, or what is the mechanism of the circulation of the amniotic fluid. So what is the importance of this amniotic fluid? It acts as a shock absorber. This is the first credit that I gave in the beginning of my session here. So it's a shock absorber. Allows plenty of room for fetal movements. Baby need not stay at one point. So initially, of course, as the baby grows older and older, as it reaches 34-36 weeks, the space becomes less, but till then baby has a freedom to swim within this amniotic fluid. It's a very good thermostat for the fetus, right? It maintains the temperature of the fetus irrespective of the maternal temperature or external temperature. It may be a source to some extent for the nutrition of the baby, right? You know, swallowing and some amount of the nutrients could be absorbed, whatever that is present. It's very, very important for fetal lung development. Students, please remember, one of the important complications of decreased fluid in early pregnancy is that the babies can go for pulmonary hypoplasia. Lung development is very, very critically dependent upon the amniotic fluid mechanics, movement, exudation, absorption. So this kind of thing should go on for a good lung development. Otherwise, there is pulmonary hypoplasia. During labor, whenever the uterus contracts, you know, if there were to be, remember, this is the baby and this is the umbilical cord, and you have amniotic fluid all around. Even when the uterus contracts, the contraction pressure spreads all round the baby uniformly. Imagine if there were to be no amniotic fluid, probably this is the placenta, this will be the umbilical cord. So when the uterus contracts, the umbilical cord loop somewhere here can get totally compressed. So this cord compression is very much avoided because of the presence of amniotic fluid, right? One more important aspect of amniotic fluid is the pressure. Whatever I told you here, the pressure which is uniformly transmitted will help the cervix. The amniotic fluid bag will come and sit here, and this pressure which is exerted on the internal os of the cervix will help in the dilatation of the cervix, at least to some extent. That's why very early rupture of membranes or premature rupture of membranes will slow down the progress of labor. So presence of membranes is a boon for good dilatation of the cervix. And when the membranes rupture, the fluid flushes the genital tract here, and whatever infective material that is there in the vagina can get flushed out, and it creates a wonderful aseptic passage for the baby to come out. Look at this nature's mechanism, so wonderful. The sterile amniotic fluid will flow through the vagina, washing away all the septic material, whatever it is there, and through that well-washed passage, the baby can come out unscathed, right? No possibility of infection. So what does it contain? It has a specific gravity of 1010. 99% is water. So, and osmolality is very similar to the maternal serum. It contains, along with the other components, lanugo hair, amniotic cells, and vernix caseosa. Okay, these are the unique components of amniotic fluid, which is not present in vaginal secretion or cervical secretion. Many a times, to differentiate whether it is amniotic fluid or some excessive secretion of the cervix, if you find a small piece of vernix, or if you find the lanugo hair, or under microscope if you are able to demonstrate amniotic cells with some special stains, that is an indication that membranes have ruptured and the amniotic fluid is leaking. Otherwise, it may be very difficult to prove that this is amniotic fluid. And coming to the volume, roughly at 10 weeks, it is about 30 ml. 20 weeks, it's almost 300 ml. 30 weeks, 600 ml, and maximum is reached by 32 to 34 weeks. Beyond which, it starts once again decreasing, and at around 40 weeks, it's about 800 ml, and you know, at 42 weeks, it drops down to 400 ml. So, this is how the volume varies at different periods of gestation. What I mean here is the total volume of the amniotic fluid in the uterus. And how do we assess this? How do we really know what is the amount of amniotic fluid that is there in the uterus? For an obstetrician, during a clinical examination, it would suffice if I am convinced that the amount of fluid that is there is enough. So clinical assessment would only tell us whether the liquor amnii quantity is adequate, decreased or increased. So we need a clinical assessment which is more of a subjective assessment. We always depend on the tension that we get while palpating. If the uterus is very tense, then the fluid could be more. If we are very comfortably palpating all the fetal parts very superficially, it could be a decreased amniotic fluid. And also you have what is called ballotability. If the fluid is adequate inside, you can move the baby across the walls from one wall to the other with your hand movement. This is called ballotability. This is possible only when the amount of liquor is good. Again, fetal heart rate intensity. If it is very faintly heard, probably fluid is more. It needs to be transmitted through the fluid. If the fetal heart sound is heard very loudly, along with the other features which I described, you can keep in mind the possibility of the decreased liquor. Again, very simple thing that we teach from the beginning is about the size of the uterus. If the size of the uterus is more than the period of gestation, one possibility that you should keep in mind is the increased liquor. If it is less than the period of gestation, you should always keep in mind the possibility of oligohydramnios or decreased liquor, right? You have an objective assessment. Whenever you are in doubt, you can send for an ultrasound and they can measure what is called amniotic fluid index. So if this is the abdominal cavity, rather the superficial abdomen, they divide the abdomen into 4 quadrants, and in each quadrant they are going to look for the depth of free amniotic fluid. When they are looking for the amniotic fluid, there should not be any cord loop or fetal parts. A clearly visible amniotic fluid measured in this quadrant, measured in this quadrant, and also measured in this quadrant. So all the 4 quadrants, let us say the length is 3 cm here, 1 cm here, 4 cm here, here it is 3 cm. So 3 plus 3, 6, 6 plus 4, 10, 10 plus 1, 11. So amniotic fluid index is given as 11 centimeters. So this is an objective measurement. Anybody who measures will get very close to this measurement. 0.5 or 1 centimeter, this side, that side should be fine. So this is what is called amniotic fluid index, and this is what the sonologist helps us to say whether there is any decreased or increased fluid. So normal amniotic fluid index should be between 5 and 25. Less than 5, it is decreased. More than 25, it is increased amniotic fluid. The other measurement that is taken is you scan the whole of the abdomen. At some point where you feel this is the deepest pocket, you just measure that single pocket. Many a times, when you are measuring at different quadrants, you may not really get hold of a pocket which is free from umbilical cord, free from the baby's hand, or free from other fetal parts. It may be very difficult to identify that kind of space in all the 4 quadrants. So you can just look for one single pocket which is probably the deepest of all. So take that pocket and measure. It is called single deepest vertical pocket measurement. In fact, this measurement is recommended by most of the organizations as the best method to diagnose the amount of liquor. So normal will be between 2 to 8 centimeters. If it is less than 2 centimeter, we say oligoamnios. More than 8 centimeter, it is called polyhydramnios. Right? So this is the measurement I have shown you. Each quadrant you can see that they have avoided the fetal parts. You see here there is a fetal part. So they have taken it adjacent to it. Here also they have taken it, but we don't know if there is any kind of overlap. Right? But this is the single deepest vertical pocket measurement which has given it as 12 centimeter. Hope I am clear with of course, this is abnormally increased amount of liquor. So, what are the abnormalities that you can expect now? We are talking about volume, but there are other abnormalities also. Color wise, amniotic fluid is a kind of grayish watery fluid. Because of its contents, it is of that color. It could be blood stained in case of abruptio placenta. It could be meconium stained whenever the baby has passed meconium, probably due to distress or maturity. Then it could be yellowish or orangish in color. This is usually occurring in case of RH incompatibilities, right? RH sensitized babies can have this color of amniotic fluid, right? Coming to volume abnormality, AFI less than 5 or single vertical pocket less than 2 cm is called oligoamnios or oligohydramnios. AFI more than 24 and single vertical pocket more than 8 cm is called polyhydramnios. Sometimes there is absolutely no liquor, totally absent. You cannot find a single speck of radiolucent, rather sonolucent area to measure the liquor. That condition is called anhydramnios, which means there is no liquor. So now we will study the individual problems of the amniotic fluid volume, and each one could be a short note question for you. Oligohydramnios could be a short note question. Polyhydramnios could be a short note question. So oligohydramnios means reduced liquor. In terms of quantity, if it is less than 200 ml at term, it is called oligohydramnios. In terms of single vertical pocket, deepest vertical pocket, if it is less than 2 cm, it becomes oligohydramnios. If the AFI is less than 5 cm, AFI is 4-quadrant addition measurement. If it is less than 5 cm, it is called oligohydramnios. Another statistical definition could be at any period of gestation, you have norms. If it falls below the 5th centile for that particular period of gestation, then you can call it oligohydramnios, because most of the definition is for term pregnancy, whereas here if it is less than 5th centile, it's a good indicator at any period of gestation, right? So roughly 1 to 3% is the incidence that we find in amongst the pregnant women, the condition of oligohydramnios. Amongst oligohydramnios, we usually don't say mild oligohydramnios, moderate, severe. That kind of grading of severity doesn't exist for oligohydramnios. But sonologists, sometimes when the AFI is between 5 and 8, they use the term borderline oligohydramnios. But obstetric definition, students, please remember, AFI should be less than 5 to call it oligohydramnios, or the SVP should be less than 2 cm. So why oligohydramnios occurs? So see, whenever there is problem in fluid production, whenever there is fluid loss, these two conditions can cause oligohydramnios. So fluid production, production is usually by the baby. So baby production could be dependent on the baby itself, or it could be dependent on the placental circulation. See, if the kidney has to function properly, the kidney should receive good perfusion, and the perfusion comes from maternal side, that is through the placenta. So if the circulation from the placenta is affected, then renal system will not receive good perfusion, urine secretions will come down. Similarly, if the kidneys themselves are not functioning, or if the outlet of the kidney is at fault, then the urine output is affected in the fetus, hence the babies can have problem. Now it becomes easy for you to understand how the oligohydramnios is caused. Renal agenesis, clear, kidneys have not developed, so no fluid. Obstructive uropathy, so there could be usually very important cause for obstruction in fetus is the posterior urethral valve, right? So there is a block, usually bladder is grossly enlarged, no urine getting into the system, right? So in such cases, again, obstruction to the urinary flow can cause oligohydramnios. renal dysplasias, aplasia or dysplasias. Usually in agenesis, there is total absence of fluid almost, right? It is one of the important cause of anhydramnios in very early pregnancy. Probably by 14 weeks, 16 weeks or 18 weeks, you will see that only baby is there and no liquor at all, what I mentioned as anhydramnios. So that could be there. Polycystic or multicystic kidney in the baby can also predispose for oligohydramnios. Chromosomal abnormalities in the baby can predispose. Now coming to the placental circulation, which I mentioned, IUGR, or the term that we use nowadays is fetal growth restrictions. Fetal growth restriction usually secondary to uteroplacental circulation insufficiency. That means what happens here? The baby has got vital structures, right? So vital structure is heart, brain and adrenals. So this part is getting good blood supply. The lower parts will not get good supply. So kidney becomes one of the structure that is getting less amount of blood supply. So less amount of blood supply, you know, what is the key feature in ultrasound? HC, head circumference and abdominal circumference. If you take head circumference is becoming more and more, abdominal circumference is becoming less and less in fetal growth restriction. So this kind of situation affects the kidneys and thus the kidney circulation decreases, urine output comes down, it results in oligohydramnios. It's a compensatory mechanism, right? So IUGR or FGR could be associated with oligohydramnios. If the baby is dead, definitely no urinary secretion. It goes for gradually developing severe oligo and finally anhydramnios. Post maturity, I told you at 42 weeks, the amount of liquor is 400 ml. Right? So if it goes beyond that, 43 weeks, 44 weeks, it could be very less and your sonologist will give you the interpretation that the baby has oligohydramnios. And the last one which I told you, liquor is getting escaped. So there could be, the membranes might have ruptured. There could be a very slow leak that is occurring which the patient has not noticed. In such cases, the clinical examination and ultrasound examination can reveal oligohydramnios. If it occurs before term, we use the term PPROM, preterm premature rupture of membranes, or if it has occurred at term, it is called premature rupture of membranes. Before the patient goes into labor, membranes have ruptured, and if the membrane rupture has been noticed by the woman in terms of the liquor escaping, then fine, you have the history. Sometimes many of the patients might not have noticed a very small leak and gradually the liquor would have totally got drained away and that can result in oligohydramnios. Placental insufficiency due to maternal hypertension, mainly the preeclampsia and eclampsia, twin-to-twin transfusion syndrome. One twin will have so much of fluid, the other twin will be starving without any fluid. There is oligohydramnios. It is in fact called oligo complex. One twin with polyhydramnios, other with oligohydramnios. Amnion nodosum, failure of secretion by the cells of the amnion of the placenta, covering the placenta. And sometimes if the patient has come at 30 weeks, 32 weeks with abruptio placenta, slightly moderate, small separation of the placenta, such cases can develop mild amount of placental insufficiency and again oligohydramnios can result. Mostly we don't manage abruption conservatively, but when we manage them conservatively, some of them can end up with oligohydramnios. The maternal causes, I told you, hypertension. It occurs in pre-existing diabetes. It doesn't occur in GDM. In GDM, you see the other way. You see more liquor, polyhydramnios. But in case of pre-existing diabetes with vasculopathy, so which can be easily diagnosed by your retinal examination. If there is a retinopathy in such patients, you may encounter oligohydramnios. So diabetes with oligohydramnios will many a times prove that I may be dealing with a pre-existing diabetes even if the patient doesn't give that history. So maternal drug intakes, especially beta blockers and ACE inhibitors, right? Prostaglandin synthetase inhibitors, indomethacin and etc. can cause oligohydramnios. For this reason, we try to avoid these group of drugs in pregnancy, right? And all said and done, most of the times we may not be able to know why this has occurred, and that comes under the diagnosis idiopathic. So how do we diagnose? In the history, without fail, ask for any history of leak per vaginum, fluid leak per vaginum, history of hypertension, chronic maternal diseases, which I have already mentioned, and any history of intake of medications that can cause oligohydramnios. Please remember NSAID, ACE inhibitors and beta blockers. These are the most important ones that you should remember. And on examination, I have already told you once, the uterine size doesn't correspond to the period of gestation. It is smaller, then fetal parts are very easily felt, and persistently baby will be in one position. You examine today, if it is breech, next week also it comes, it is breech, because it cannot move inside, right? FHS is very loudly heard, and ultrasound will confirm the diagnosis. So when you do an ultrasound, you may pick up the etiology also. You may find out that there is a fetal growth restriction which is associated with oligohydramnios. You may pick up the anomalies in the baby. You may find that there is renal agenesis or a huge bladder because of outlet obstruction in the baby, which is the cause for oligohydramnios, right? In case there is absence of kidneys and oligo, it is called Potter's syndrome also. You can pick up enlarged or cystic kidneys, and sometimes twin-to-twin transfusion syndrome in case of twin pregnancies also can be picked up by your ultrasound. So importance of ultrasound in oligohydramnios is it helps to diagnose oligohydramnios. It also helps sometimes to diagnose the cause for oligohydramnios. So what are the problems of oligohydramnios? Early pregnancy, it can result in abortion because of the association with aneuploidies, right? That is the commonest cause for abortion. More than 20 weeks, it causes pulmonary hypoplasia. It can cause skeletal deformities. Many a times what happens when the fluid is very less, you can see that some bands, adhesive bands develop between the walls of the uterus, right? So the baby is here. Here is the leg. So some bands develop here, and these bands between the two walls, because they are very close to each other, these bands will act as some knife-like structure, and it can cause constriction. It can cause constriction here, constriction along the joints of the baby, and sometimes the constriction could be so much that it can detach, it can completely detach that part of the baby from the main body, right? They can have auto amputations. They can have deformities of the bone, talipes, etc. So any of such deformities, and fingers could be separated. So you can expect auto amputations because of the amniotic bands, and less amount of liquor can also predispose for preterm labor. It can kill the baby, especially if the etiology is uteroplacental insufficiency or any life-threatening anomaly, and it could be the cause also for fetal growth restriction. When the patient goes into labor, it can cause cord compression and fetal distress. It is responsible for persistent malpresentations. You know, breech, transverse lie, etc. can get corrected by 36 weeks if the liquor is adequate. If the liquor is not adequate, it doesn't get corrected, and thus malpresentations can remain, which can lead to surgical interventions in terms of cesarean. The associated morbidity like hypertension, diabetes with vasculopathy can trouble the mother, or even the anomalies of the baby can be troubling the baby. Perinatal mortality, preterm delivery, possibility of abruptio placenta, intrapartum stillbirths. If you allow them for a vaginal delivery, many a times because of this cord compression, uteroplacental circulation hazards, the baby can die during labor. And in case the oligo has occurred because of ruptured membranes, patient can go for chorioamnionitis, intrapartum infections. So how do we manage early pregnancy oligohydramnios, you have got nothing much to do. You may have to just allow the patient to proceed or abort, right? Otherwise also, you can even tell the patient that if this oligo persists for a long time, baby's lungs will not develop and there could be a serious issue with the baby, and give her the option of either continuation or termination of pregnancy. Again, in second trimester, they usually go for intrauterine fetal demise because of pulmonary hypoplasia or uteroplacental insufficiency or some inherent cause in the baby itself, which is the cause for oligoamnios. Most often fetal abnormalities associated conditions, oligohydramnios, you can consult the fetal medicine experts, take their opinion. If any kind of solution is available, we can try to do, especially the TTTTS syndrome, in which you can use laser ablation of the connecting vessels, right? You can do clamping of one of the umbilical cord and save one of the babies, right? So there are certain interventions that are available. Maternal diseases like hypertension, diabetes, etc. needs to be optimized. You should control it well, which also can help us to overcome the problem with oligoamnios. More of the management is aimed at optimizing the fetal outcome, right? So ultrasound, Doppler are the key investigations that are done in all these babies with fetal growth restrictions, and depending on the duration of gestation, severity of the oligohydramnios or FGR, and how much of uteroplacental insufficiency has happened to the baby, we are going to manage the babies by delivery at appropriate period of gestation. This will be dealt in detail in a session on fetal growth restriction. Idiopathic oligohydramnios can be managed by giving more fluids either intravenously or asking the patient to take 3 to 4 liters of fluid orally, which can get into the uteroplacental circulation and improve the quantity of amniotic fluid. Amnio infusion, directly instilling fluid into the amniotic cavity, is not routinely advocated, but some centers practice this during labor to prevent the cord compression, right? It is not a universally accepted method, but many people practice this, right? Nitric oxide donors, especially the RG nitrate, which is being used by many people with an intention to cause vasodilatation and good circulation to the baby, are not evidence-based, have not been found to be beneficial, but people still use this, right? So oligohydramnios, to summarize, fetal anomalies or diseases, you go for pediatric surgeon's opinion and fetal medicine expert consultation might help. In case of maternal diseases, you have a role to play, probably with a physician, optimize her condition. In case of fetal growth restriction, you give steroids and see that the lungs mature fast and time the delivery depending on Doppler and ultrasound picture. If it is idiopathic, you can try with hydration treatment and try to prolong the pregnancy till 38 weeks and then deliver out her. If the patient has oligohydramnios due to leaky membranes, then management is either as PPROM if it has occurred before term, as PROM if it has occurred after term. So usually here also we try to continue pregnancy to term in PPROM, whereas in PROM we wait for spontaneous onset of labor or induced labor. Right? Now, with this summary, we have finished one extreme aspect of amniotic fluid. Now coming to the other extreme, which is called polyhydramnios. So very similar to the definition of oligo, you can say when it is more than 95th centile for the gestational age, or single vertical pocket more than 8 centimeter, or AFI equal to or more than 25 centimeter, or quantity wise, when the whole of the amniotic fluid, if you measure, if it is more than 2 liters, then we use the word polyhydramnios. And the incidence is not as frequent as oligo. It is 0.4 to 0.5% of the pregnancies. But you have a severity classification in case of polyhydramnios, right? So depending on the AFI and SVP, that is single vertical pocket, 24.9 to 29.9 is defined as mild polyhydramnios, 30 to 34.9 is moderate polyhydramnios, 35 and above is called severe polyhydramnios. In terms of single vertical pocket, 8 to 11 is mild, 12 to 15 is moderate, and more than 16, right? 16 and more than 16 will be severe polyhydramnios. So polyhydramnios, contrary to oligo, of course, oligohydramnios also, when suddenly the fluid goes out, it is an acute oligohydramnios. But we classically don't use the term. But in polyhydramnios, it can occur acutely or it can occur over a period of time. When it occurs suddenly, massive accumulation, and this usually occurs in the mid-trimester of pregnancy, this kind of problem, and this is called acute polyhydramnios, right? And commonest cause would be the twin-to-twin transfusion syndrome or chorioangioma of the placenta, which massively secretes the amniotic fluid, but fortunately acute polyhydramnios is very, very rare. Chronic hydramnios is common. It is because of the gradual accumulation of the fluid. So fetal etiologies, whenever the swallowing is affected, when the baby is not able to swallow the fluid remains. So in case of anencephaly, because of the loss of swallowing reflex, which is determined by the central nervous system, babies will have polyhydramnios. Muscular dystrophy also is associated again because of the neuromuscular incoordination which affects the swallowing. Neck swellings which can have obstruction, which can obstruct the swallowing, esophageal atresia, duodenal or jejunal atresia, or TOF, tracheoesophageal fistula. All these things can cause difficulty in swallowing or obstruction to swallowing, and somehow the mechanism of swallowing is affected, and this results in polyhydramnios. Coming to situations wherein the baby produces more of urine, maternal disease related, mainly diabetes, mainly GDM, uncontrolled GDM can result in because of the polyuria as a result of hyperglycemia. Maternal hyperglycemia causes fetal hyperglycemia, causes fetal polyuria, right? So this is the mechanism of causation of polyhydramnios. RH and red cell antibody induced. So isoimmunization either because of RH factor or other RBC antibody induced. Twin-to-twin transfusion syndrome, I told you, in one baby there could be polyhydramnios, in the other there could be oligohydramnios. Twin reverse arterial perfusion, very similar to TTTTS also, you can have this kind of polyhydramnios. There is one more mechanism here. Whenever some of the membranes are exposed, especially the meningeal exposure in open neural tube defects, you expect polyhydramnios. Anencephaly, spina bifida, holoprosencephaly, right? In all these cases, because the meninges get exposed out, the babies will have more amount of liquor around them, and that causes polyhydramnios. So maternal problems, fetal problems which increase the urine output, then meningeal exposure which causes more of exudation, and earlier we just mentioned about the swallowing problems which is neurological or structural. These are the causes for polyhydramnios. Maternal infections like toxoplasmosis, parvovirus, especially the B19, herpes simplex, rubella, CMV can cause abnormalities and also polyhydramnios. And I have just told you maternal diabetes mellitus. Pre-existing without vasculopathy can result, but with vasculopathy you usually expect oligohydramnios. Rhesus disease and placental problems like arteriovenous fistula and chorioangioma of the placenta. Chronic polyhydramnios is the commonest disease that we encounter, entity that we encounter. Enlarged abdomen, history of neural tube defect in previous siblings. The mother might say, I had delivered a baby with neural tube defects, anencephaly, spina bifida, etc. So then you can expect the recurrence during this pregnancy, and that could be responsible. So history of this also could be there, and it can cause respiratory embarrassment because of the over distension of the abdomen to the mother. She will have a lot of discomfort for breathing, and because of the compression of the gravid uterus, hugely enlarged gravid uterus, pressure in the inferior vena cava can cause massive edema of the legs, varicosity of the legs, and hemorrhoids, and also vulval varicosities. Occasionally it can also bleed. Rare cases of acute polyhydramnios, she can present with acute pain abdomen and vomiting. History of diabetes mellitus could be obtained. On examination, the skin is very much stretched, shiny, and over distension of the abdomen with engorged veins. We usually ask you to present the inspection findings, how the abdomen is distended, what is the texture of the skin, what about the hernial orifices, what about the umbilicus. So here you have lot of findings: engorged veins, everted umbilicus, shiny and stretched out skin, over distended abdomen, right? And fundal height more than the period of gestation. When you measure the abdominal girth at term, it will be more than 100 centimeters. Fetal parts you cannot make out well, and most often there could be malpresentation. Baby can be very comfortably lying in whatever position it wants. Now it will be breech. After some time you may find that it is transverse. After sometimes it could be vertex, right? So FHS is not as comfortably held as you hear in other cases, right? And you will be able to demonstrate fluid thrill. Fluid thrill is usually demonstrated by keeping the ulnar border of the hand over the midline of the left hand, and better would be keeping the thumb. Think that this is the midline, or rather let me show in a diagram. Okay, so this is the midline. You are going to keep the radial border of the hand on the midline like this, and with the other hand, these 4 fingers are kept on the left side of the abdomen, and you just tap on the right side like this. And if you are able to feel that thrill, this is called fluid thrill, and this fluid thrill is classically found in case of polyhydramnios. You need to look for blood sugar and HbA1c, because diabetes is one of the very important causes. Blood grouping and RH typing, and if it is RH negative, immediately go for ICT, indirect Coombs test. Ultrasound examination, of course, to confirm the diagnosis, and also to pick up any anomalies in the baby or problems in the placenta, right? And of course, it confirms the diagnosis of malpresentation. And again, it's very important for you to tell about the viability of the baby. Many times you may not be able to hear the FHS properly, and it may pick up twin pregnancy and abnormalities associated with twins. So what are the complications of polyhydramnios? Polyhydramnios in 25% of the cases is associated with preeclampsia. Because of the overdistension, patient is prone for preterm labor. So sometimes we may have to induce preterm labor to decrease the severity of complications in the mother, or sometimes it can be spontaneous also. It most often results either in preterm premature rupture of membranes or term premature rupture of membranes, that is PROM. Malpresentation, persistently floating head. Head doesn't engage because it is very comfortable. Why should it go into the pelvis and feel uncomfortable? It doesn't engage at all. And whenever the membranes rupture, sudden gush of fluid causes decompression of the uterus, which can cause abruption. It's a very important life-threatening complication both for the mother and the baby. Again, during labor, it can cause early rupture of membranes, and because of the malpresentation and non-application of the head, cord can come out, and or malpresentations, it can result in cord prolapse and death of the baby. Uterus may fail to contract in the labor and also after the labor. That is, it can cause postpartum hemorrhage, and placenta may not get separated because the uterus fails to contract, and many a times you may need to do cesarean sections, you may need to do forceps deliveries, or you may have to do manual removal of the placenta and manage the postpartum hemorrhage energetically. Fetal complications could be because of preterm delivery, because of infection, abruption, cord prolapse, operative deliveries, of course, innate problems like anomalies, or because of the maternal disease, the baby can go for postnatal hypoglycemia, or Rh negative or isoimmunized babies can go for hyperbilirubinemia, or problems that you can encounter in a baby of a diabetic mother could be there, or baby can have high drops. All these things can increase the perinatal mortality. So how do we treat? Fortunately, most of the cases of polyhydramnios will not lead to very severe complications, and that kind of severe polyhydramnios is very rare. Probably 20 to 30% of all the polyhydramnios can have severe grade, that is more than 35 AFI or more than 16 single vertical pocket. Most of them are mild or moderate polyhydramnios. If you know why the polyhydramnios has occurred, and if it is correctable, you can attend to it and try to do something. With anomalous babies, probably you will not be able to do anything. Twin babies can definitely help with fetal medicine experts. In case of severe polyhydramnios, we admit the patient because we foresee the possibility of preterm delivery. We give steroids, and you may have to do abdominal amniocentesis. You put a needle and drain out fluid, and it gives only a temporary relief because quickly the fluid will accumulate, but it can temporarily bring some relief to the maternal discomfort. Indomethacin is one drug. If you remember, the reasons for oligohydramnios, which I told you, NSAIDs can cause oligoisid. Here we utilize that. We exploit that property of NSAID. We use indomethacin in the dose of 25 to 50 milligrams 2 to 3 times a day, and this can cause decrease in the amount of liquor, but unfortunately it can cause premature closure of ductus arteriosus. MCQ question for you, please remember this. So it can cause premature closure of ductus arteriosus. So we very frequently don't use it, but for a short period, 3 to 5 days, you can consider using if it is causing too much of a problem. If in early pregnancy, acute polyhydramnios, and you find life-threatening problems, you may have to, problems in the baby, maybe anencephaly, you may have to terminate pregnancy. So how do we manage them in labor? Do a vaginal examination to rule out cord prolapse and also to confirm the presentation after membranes rupture. Oxytocin may be necessary because most often they can have uterine inertia. Active management of third stage of labor is very crucial to prevent atonic PPH, and after birth of the baby, you should be watching carefully for the possibility of retained placenta, postpartum hemorrhage and shock. So maybe you should be equipped to handle this with some amount of blood reserved. Baby should be thoroughly examined by the neonatologist for the presence of any anomalies, and malpresentation, cord prolapse, abruption, etc. may require, and of course even in the third stage may require any surgical interventions. So polyhydramnios, once you detect by ultrasound examination, you do a detailed ultrasound and find out whether there are any anomalies, right? And you also look for the movements of the baby because the neuromuscular problem could be there, right? And look for the stomach, especially for any obstruction, double bubble of the appearance of the stomach in duodenal atresia, etc. Or absence of stomach bubble may tell us that there is esophageal atresia. Suspected anomalies, right? You are going to refer to fetal medicine expert and take pediatric surgeon's opinion. And in case of, if this is not there, you have to investigate the mother to rule out diabetes, infections and red cell antibodies. And if you find any of these things, then maternal and fetal medicine expert, you control diabetes. Red cell isoimmunization is to be managed, individualized. You can learn about this, how we manage these things in my session on the Rh negative and RBC antibody isoimmunization session, and maternal infection has to be treated with appropriate treatment, right? In case of idiopathic polyhydramnios, antenatal steroids, if you find that, so much of pressure, cervix could be shortening, which can tell us that there is a threatened preterm labor, that she may go into labor anytime. You equip yourself to handle that baby by giving steroids and counsel them about preterm delivery. Be ready for facing abruption. Be ready to do a cesarean section whenever it is necessary. Also, antepartum and postpartum hemorrhage risk has to be explained, and operative intervention possibility should be kept in mind, right? Management of pregnancy as per the problem that you have detected. Any of these problems you have detected, you are going to manage. So just to summarize the polyhydramnios, if you have anomalies, consider termination or refer to fetal medicine. Twin associated polyhydramnios, always fetal medicine people might help us, right? This particular facility may not be available everywhere in India, but whenever it is possible to obtain the help of a fetal medicine expert, it is very ideal that in such situations you can take their help and once for all cure this problem. In case of maternal diseases, you optimize the condition. Diabetes, optimize, right? Acute and massive polyhydramnios, you have to do serial amniocentesis and make the woman more comfortable. Idiopathic, sometimes, rarely amniocentesis may be required. Otherwise, you have indomethacin, regular monitoring, steroids, selective induction. You can rupture the membranes with a controlled artificial rupture of membranes so that you can do it under supervision and prevent the cord prolapse, and or else you can do a cesarean section. So with this, we conclude the session on the liquor, importance of liquor, the oligohydramnios, some unfortunate cases of anhydramnios, and the problems associated with that. So these things are most often asked as important short note questions for you, and in clinical case discussions, we expect sometimes if you get a case of GDM or you get a case of hypertension, you get a case of IUGR, you may have to say a few words about oligohydramnios, polyhydramnios, some kind of management options that are available for these conditions. Thank you, students.